it is an honor and a pleasure to talk to you about sort of subsequent therapy options for kidney cancer. I was actually also sitting there in awe listening to Dr. Cockrell's talk because the last time we did this conference was in 2019, and the slides are completely different. I mean, the entire treatment, everything he basically just said was not yet standard of care or barely standard of care. And, I know for a fact, actually, people in this room who've had kidney cancer and have gone through this journey, didn't always get these treatments because we didn't know about these things only a few years ago. And it's like the field is moving so fast. And actually, that's part of why this talk is a little challenging, is because it's moving so fast. Sometimes we don't still have all the answers, but so nice to see things getting better. I mean, to Dr. George's point, those survival data, we just don't have the data yet, but we all know it is way better than it was sort of even 5 years ago, and it's fantastic. So this is sort of the whirlwind of FDA approvals we have had in the last 20 years, although a lot has happened in the last decade or so. This is the same overwhelming picture that Dylan put up, Dr. Cockrell put up, to show you all the different types of treatments that we have and the different mechanisms that are really trying to attack the cancer from different sides. That being said, there's really kind of three main categories here. And what we do is try to flip kind of from one to the other, and then really the backbone of subsequent therapy for clear cell and even non-clear cell kidney cancers these days is really these ones on the left, which is this anti-angiogenic, or what Dr. Cockrell is calling TKIs mostly, which are, small molecule inhibitors that really target certain proteins in the cancer and are predominantly, or all of these on the list are pills. And you can see like the ones that end in IB, IB are these small molecule inhibitors and are relatively similar, but target slightly different receptors. And we've learned through time that if you've had one, it doesn't necessarily, and your cancer grows through one, it doesn't necessarily mean that the next one's not going to work. And actually, a lot of people have success flipping from one to the other. And what we haven't really figured out is sort of what is the optimal order and which is the best for which patient. And, that's a huge area of ongoing research. And then you can see the immunotherapies that almost everybody these days gets first, as Dr. Cockrell explained. Although if you didn't get it first and you can get it, then you can give it later. And sometimes we try it later anyway. And then kind of our older treatments, but still very much used in some contexts, are these called the mTOR inhibitors, everolimus being the more common one, which is also a pill. And then I cannot not mention high-dose IL-2, which we don't really use clinically very often. But in my experience, every time I've ever been at this conference, there's always like someone in the audience that got it 20 years ago that raises their hand at the end and says, it cured me. Why is it not on the slide? So I just want to mention it as something approved for kidney cancer, although it has really fallen out of favor with the newer immunotherapies. So, if a patient has had treatment, typically combination therapy first for their kidney cancer, how do we decide what's next? And it's actually a very nuanced, hard decision in many cases. But the things we look at prior treatment, like what did they already get, right? Obviously, you're not going to give them the same thing that they already got. How did it go? Did they have certain side effects that might make some drugs more difficult than others? How much, like what is their cancer doing? Or is this a slow growing cancer where you have time for it to grow a little further, and not causing a lot of symptoms? Or do you like really need that cancer to shrink to make this patient feel better? And then also, the other medical comorbidities, someone with very difficult to control blood pressure, you don't necessarily want to pick another thing that causes their blood pressure to go sky high, et cetera. And I think the somewhat unacceptable reality of later line treatment for kidney cancer is that the goal is really maintaining quality of life, increasing life expectancy as we can via disease control. But it's a little different than the first line setting. I mean, when we're first meeting a patient, if we're using that C word of cure sometimes, right? We're going for cure. And so if we can, we try to pick a treatment where we can achieve that. Once people have had immunotherapy and their cancer is growing, it's typically not a curable cancer. And so really the balance of quality of life for as long as you can is the right approach here. So as you can see, so this is the same NCCN guideline that Dr. Cockrell showed for first line. So this is what, oncologists in the community, when they're looking up, okay, what do I do next after a patient has already had some treatment? What is the preferred treatment? And you can see no matter what they got first, the recommendations from this guideline committee is there's actually nothing preferred. We don't know. We don't know what is the best answer here. And I think that's very telling for how quickly things have moved. And we've compared some drugs to old drugs, but not to each other. And even this is changing rapidly. I mean, I'll show you some data that just came out a month ago that is trying to answer some of these questions, but we still don't know the right answers. And so you can see basically a laundry list of options. And all of these are, reasonable potential options for each individual person. The IO on the left side, so that stands for immuno-oncology. So one of these immunotherapies that is kind of the backbone of first-line treatment. We choose kind of what people should get based on whether they've had that. Nowadays we're getting to the point where almost everybody's already had it, but there's still, a number of people that have been on just a pill for years and haven't had immunotherapy yet. And so we tend to include it in second line treatment in that case. But for most people who have had immunotherapy before, the standard is really one of these pills or TKIs that target the blood supply. So this is kind of the first study or this is one of the studies that support one of the options I think that's used probably most frequently in this, what we call second line setting. So a drug that is given second after your first line. And obviously, if you've gotten cabozantinib first, you wouldn't give it second also. But for people that got another regimen, I'd say this is one of the more widely used drugs. So this study was called the Meteor study, essentially gave half the people this drug cabozantinib, half the people the old standard everolimus. You can see, it improves. This is what we call overall survival curve. So it's just how long people live. And you can see it's a little bit separated from the other curve. It's not overwhelming, but it is. This is the drug that sort of established cabozantinib really as a nice footing as a second line option. And then the other one that I think that's used very commonly is actually two drugs. And so this is a combination of lenvatinib plus everolimus, so essentially the old standard plus a newer drug that's a pill. This study was, done in a similar situation where people have already been treated with at least one prior systemic therapy or treatment for the whole body. And again, these are just curves of sort of showing how effective each treatment is. This is what's called progression-free survival curve, like how long until your cancer grows. And that blue line there on top is the combination. So the two drugs instead of one. So really, if you're looking at it compared to the last study, it's like blue compared with green. The green was the bottom line on the cabozantinib study too. And then this is what I was commenting on. So this was actually data that was just presented about a month ago at one of the European conferences that actually was nice to see, actually comparing two treatments that we use a lot in this setting against each other. Basically said, oh, should we use pill X, cabozantinib, or should we use lenvatinib plus everolimus, essentially one pretty active drug versus two active drugs. And this study basically showed there was a little bit of benefit into time to cancer growth and a benefit in the percentage of patients with a meaningful tumor shrinkage. But you can also see that if you look at side effects, they're higher with two drugs than one, somewhat logical. So, you can get a little bit more cancer shrinkage and a little bit longer on the drug, but you're on two drugs instead of one with a little bit more side effect. And you can see the different side effects are different between the two regimens. And so I think either of these options remain very reasonable in that non-preferred pick category. But people may prefer sort of two drugs to one in certain situations, or based off the slight differences in side effect profile. And I think, the biggest thing with any of the choices, and I've talked about cabozantinib and lenvatinib plus everolimus, but again, there's a whole list of other drugs on that list that you could try for one reason or another. Um, you know, I think the having good supportive care around it, having good communication with your care team, making sure that we're on the right dose, that each patient is on the right dose for each patient. This is actually UNC data here that looks at what we call acute care visits, right? So there's a huge movement to try to keep patients out of the emergency room, out of the hospital. And we looked at our own experience with the different oral regimens. It's a little bit confounded because we used some a long time ago and some more recently. But it kind of parallels some of the clinical trial data about side effects. The other thing I wanted to highlight is many of us in the community, in the academic community, I think were hopeful that more immunotherapy with a different partner in the future, partner drug, would be beneficial for patients. And there's actually been two recent studies that ask the question, okay, if people got immune therapy first, and then we put them on one of these pills that targets the blood supply. Is there any benefit to continuing them on immunotherapy too? And you can see, as opposed to some of those earlier charts I showed you, these lines are basically on top of each other. There's no difference in continuing immunotherapy or switching to another regimen with immunotherapy. Now, there's some unanswered questions here, like if you got immunotherapy after surgery and then it's been a while, how long is a while, and how long should we wait before we try it again later, right? And this doesn't address, a group of patients who's been a long time or maybe had an initial response to two immunotherapies, but the standard really is if you've had immunotherapy before and you're switching to something else, there's really no benefit to continuing it. And then, the other thing to say is many patients, for whatever reason, get one immunotherapy drug at the beginning and in combination with a pill. And many patients also get two immunotherapy drugs at the beginning. And so one of the questions that is asked all the time as well is there benefit of giving two immunotherapy drugs later? And there's been a bunch of different studies that have looked at this. The bottom line is that you can get a few patients, a few cancers, I should say, to shrink when you give two immunotherapy drugs later after the cancer has already grown through one. But it's pretty modest. The response rates are somewhere between 4 and 17%. So it's something we do, but rarely, as sort of later line treatment for kidney cancer. So, this is my current practice. I specifically put my name on the slide because I think this varies a lot, and I don't think that there's a right answer. And basically, if you've had two immunotherapy drugs, ipi/nivo, then I typically give either cabozantinib or lenvatinib and everolimus next. If you've had one immunotherapy drug and a TKI or one of these small molecule inhibitors that target the blood supply, I basically give the other one next. And sometimes I give one of the other things. And I think that's as granular as I can get with those things because it's very nuanced for each person. The other drug I just wanted to highlight, there's a number of different drugs, but this one's actually a little different. So it's called belzutifan. We heard it mentioned because it's being studied in the adjuvant setting right after surgery for kidney cancer. But it's a little bit different of a mechanism. And so it inhibits a different protein called HIF2 alpha. There's been we've essentially tried to target this protein for many, many years, and have finally made some progress. And so it is probably the newest kid on the block, the most recently approved drug. It's not quite as active in the sort of second options for treatment setting as some of the other drugs I've showed you, but it's sometimes a nice different side effect profile. And so if you have someone that's really struggled with the side effects of some of these oral medications, diarrhea, hand-foot syndrome, et cetera, you'll hear more about management of those later. Sometimes this is a nice and effective option for people. It has a very different list of potential side effects as we see with some of our other drugs, most notably anemia or low blood counts or hypoxia, low oxygen, among others. And so it's a little bit of a different experience for patients, but overall pretty well tolerated. And sometimes we see really nice long-going responses. And then, just to make a comment, basically everything I've told you is about clear cell renal cell carcinoma. And, that's only about 75% of patients. And there's many different types. In fact, even the list of types has changed since the last time we had this conference, right? And so we're learning more and more, as Dr. George told you, and we really haven't caught up on how to treat them with therapies. There's some good new data on what to do first, and very little data on what to do second. So, if you look at the guidelines for non-clear cell kidney cancers, they're basically just borrowing regimens we've developed with clear cell kidney cancers, with maybe the exception on this list of the erlotinib plus bevacizumab, which was developed specifically in papillary RCC. But we still have some, room to grow, I think, in learning how to treat these cancers. Just a plug for clinical trials. So the reason that all of this is different from, the last time we gathered, is because of clinical trials, right? So this is UNC's current kidney cancer portfolio. I'll highlight the Regeneron trial just because I mentioned high-dose IL-2, which is essentially like the new version of IL-2, trying to improve upon some of the side effects we used to see. But Duke has a wonderful portfolio of trials too. So really, I think at each stage in the journey when treatment needs to be decided upon, figuring out if there's a clinical trial that's an option rarely is a poor choice. And I would encourage it because that's how we make these numbers better. So in summary, choose subsequent therapy for kidney cancer based on prior treatment, weigh the chance of tumor response and toxicity, don't reuse immunotherapy routinely as the standard. You can try a different class of medication to see if it works, and then clinical trials might be the best option. Thank you.